To treat osteoporosis, hormone therapy can be considered as first-line treatment for prevention and treatment of osteoporosis in women that are below the age of 60 years. Once they are above 60, you have to weigh the benefit against the risk. And the susceptibility for fractures is indicated here. This is in grade A level 1B. And initiating hormone therapy in women after 60 years for the sole purpose of preventing osteoporotic fractures is generally not recommended because it carries additional risk. Next. In terms of the hormones you want to produce, you give estrogens, and different formulations of estrogens and their doses are shown here. I will speak a little bit more about the last one in the last row, that is tibolone, which is selective tissue estrogenic activity regulator. Next slide. And so this steer is indicated for the relief of inflammatory symptoms and prevention of post-menopausal osteoporosis. In other post-menopausal women above 60, the dose recommended is 1.25 milligrams, and you would increase this depending on the severity. If you have an increased risk of stroke, this agent, tibolone, should not be used in older women above 60 and in women with strong risk factors for stroke. It is also not recommended in women with personal history of breast cancer and long-term use above 5 years is discouraged with A evidence. There is also the selective estrogenic receptor modulating cells, and this is represented by the raloxifene, which improves and preserves bone density and both the spine and hip for up to about 4 years. Compared with placebo in post-menopausal women, an average risk of breast cancer in published osteoporosis trials, raloxifene reduces the risk of invasive breast cancer by up to 76%, and that is quite remarkable. Next slide. But beware of venous thromboembolism when you are using it. Next slide. Biphosphonates can also be used, and examples are shown: alendronate, mesotronate, ivandronate. But note the adverse effects as atypical femoral sharp fracture, osteonecrosis of the jaw, and then evaluate for efficacy after some years. Next slide. Recombinant human parathyroid hormone can also be used, and some of the examples include denosumab. Calcium can also be replaced. Next slide. Then vitamin D, we talked about it. Next slide. And activated vitamin D in the form of calcitriol 0.25 micrograms VD or alpha calcium or 1 micrograms daily. Next slide. The benefits of osteoporotic medications is nicely summarized in this slide, using all of these, any of these, and in terms of increase in lumbar bone mineral density, increase in hip bone mineral density, and so on is summarized here. For want of time, I won't go into the details. Next. And then the effects of osteoporosis interventions is also summarized here. Whichever intervention you use, depending on the weight of evidence and benefits, ranked A, B, C, they are shown here. Clearly, the one that stands out is estrogen. Look at this very closely. And raloxifene and alendronate and tibolone, like I've discussed earlier. Next slide. And the effects of intervention is still shown here, depending on what you are doing next. So my take home from this discussion this afternoon is that osteoporosis in post-menopausal women is common but remains silent until there is an event, and I think this is an important take home, so that our index of suspicion should be high. A careful and conscious assessment of perimenopausal women is recommended. An evaluation using standard diagnostic tools like DEXA is lacking in Nigeria. I don't know why. And opportunities for treatment should be made available much earlier. I want to use this opportunity to challenge us that we should begin to think of developing an Emson guideline that speaks to evaluation and management of osteoporosis in different populations, particularly in women. Next slide. So this, I got some materials from these references. Next. Thank you very much.
Thank you, Professor Boko. Quite intuitive. Without wasting time, we now invite Professor to speak to us on cardiovascular risk management or assessment program.
Good afternoon, Chairman, and my other colleagues. We have 15 minutes, so I will try to be as brief as I can. So I want to thank the organizers for giving me the opportunity to look at this top assessment of cardiovascular risk in people with diabetes with mellitus. So here we will be addressing the clinical intersection between the clinical medicine and assessment of this individual. Given that it is well known that there's a link between diabetes and an increased cardiovascular mortality, and this has to be stratified central to so that it will guide us to either prevent or treat. So for this presentation, I'll reflect on updates of some guidelines. So I'll be using the American Diabetes Association standard of care, the BMJ recommendation, and the frontier view. Even in looking at this, I'll also say something about the African, the sub-Saharan, or the Nigerian aspects in looking at this throughout the assessment. So in section 10 of the ADA standard of care, that is where it actually refers to for the cardiovascular risk factor that we have in people living with diabetes. And it goes along to say different ways in which we will know this risk factor, and I will be presenting that later. The BMJ is also another recommendation, but in this case, there's an individualized risk stratification use of SGLT2 inhibitors and GLP-1 therapies in this case. The only thing with this was that the population was mixed. They didn't have, they had mixed population from the UK to be able to do that. And in this classifying of the risk factors, there are certain things that also limited, particularly when it comes to Africans and Nigerians. Then the Frontiers Review also summarizes evidence that there is an increased cardiovascular and renal benefits using SGLT2 inhibitors and GLP-1 as a cornerstone for managing diabetes this time. Next slide. So why is cardiovascular assessment important in people with diabetes? Diabetes accelerates atherosclerosis. And many patients with diabetes have silent ischemia, and we know the reason because of the neuropathy that they may have. So identifying these cardiovascular risk factors early will also help us to intervene. So I'll start with the epidemiology. In terms of epidemiology, it looks at both the traditional risk and the clinical, the traditional risk and the stratified risk. First, we have the cardiovascular risk that we have in people living with diabetes. And we know that people living with diabetes, they tend to have increased risk of coronary artery disease 2 to 4 times compared to the general population. Also stroke, by 2 times, and then you have heart failure. And the myocardial infarctions that occur in them are more likely to be silent in people living with diabetes. And if not seen, they now tend to present in heart failure. So there is a need to be able to assess this cardiovascular risk. Then I am also looking at the mechanism linking diabetes and cardiovascular disease. You have the chronic hyperglycemic state that tends to lead to endothelial dysfunction, oxidative stress, inflammation, dyslipidemia, and a prothrombotic state. And then you also have the insulin resistance, which is central, particularly in those who have type 2 diabetes. And this is central to atherogenesis. And there is glycation that may also occur with the low density lipoprotein, the enhanced monocyte adhesion, and smooth muscle proliferation. Here is just a diagram to just summarize what I have said. With persistent hyperglycemia, you have an increase in the glycated AG residues. You have the ROS, that's oxidative stress, and this leads to endothelial dysfunction, which reduces the nitric oxide. You have atherosclerosis and the plaque. On the other side, you have the insulin resistance, which may also cause dyslipidemia, the oxidative stress, and you see that from both of these, the pathway still comes down. So make these individuals have an increased risk in cardiovascular complication, and so assessment of these risk factors and biomarkers are important. Next slide, please. The second one is the risk stratification. We have the traditional risk scores. And the first one is the Framingham risk score. But this is not validated in people who have diabetes because it was not used for diabetic specific, but it is known to be used in other cardiovascular. Then you have the atherosclerotic cardiovascular risk calculator from the American Heart Association and the American College of Cardiology. Both of them, in this case, incorporate diabetes as a binary factor, and they use a general population. Then the third one is the Pure Risk Stream in the UK. And in this case, it also includes diabetes duration and comorbidities, and is also better adapted for individuals with diabetes. Then the second one is the diabetes specific risk engines. This one is also based on the UK PDS study on how to predict coronary heart disease and stroke. And in this case, you use age, you use duration of diabetes, lipid, blood pressure, and because it's a risk engine, online, when you use all these things, you just put what the individual has, and it will calculate the risk of having that in them. And in this one, though it did not say anything about Africa or South Africa, if it is calculated that if they have only 10% risk, well, it's said to be mild, and if it's greater than 20%, it is high. But they agreed that for Africans or blacks, that any 10% right, a greater risk, that you should see as a strong risk, and this patient should be assessed. So then you also have the advanced, right from the advanced trial. And this one also has specific for diabetes. So there are certain things that in people who have diabetes that they have to look at. And this includes albuminuria, retinopathy, and cardiovascular. It is more useful in clinical research and less so in day-to-day practice. Now you also have the clinical biomarkers and risk modifiers that can be used. You have the traditional risk factors, age, can all get age, gender, smoking status, hypertension, and the lipid profile. Then you now have the specific diabetes markers, like the glycemic control. And here it said that glycated hemoglobin is not always a linear prediction of CBA. And this we all agree, because glycated hemoglobin will only tell us a 3 to 4 months of the control of the patient. who maybe 6 months, 8 months earlier may have had some suboptimal glycemic control that may have caused the damage. But by the time we are assessing, the patient has now become well controlled. So that's why it's not used. So in some study, you find that HbA1c does not always link, because the problem has been going on over the years and we are only assessing a small window in this patient. Then, of course, duration of diabetes greater than 10 years, and if it is for type 2 diabetes, it's okay. We know that they may also have other things. Then you have presence of complications, and then you have the novel biomarkers that you can use high sensitive CRP, like the protein, the N-terminal pro-BNP, and then you have the coronary artery calcium score. Next slide. So, next slide. Now, this is imaging and non-invasive. You can use the coronary artery calcium scoring. You have a 0 score which shows a short-term risk, and if it is greater from 99 to 100, you say it is a medium, and if it's greater than that, you say it is up to 300. The advantages are that it's non-invasive and it's superior to the risk calculator, as I said earlier, and it also helps the guide to initiate statin, comment statin in this patient, and it's included in the ADA and EST guidelines. Next slide. Now this just shows the carotid intima thickness on how it is. This is an ultrasound scan that shows the carotid intima. So there you have the waveform, and then of course the yellow line highlights the intima is the thickness. It is calculated with the Anderson score to be able to know how much calcium is deposited in the intima. Next slide, please. Then you have the stress testing. You can do stress testing using the ECG. Could be a stress echocardiogram, which the patient is stressed. You have done a laser, and then you do a post echo, or you could do a nuclear one. The advantages are that they detect silent ischemia. You can use them to stratify. Then you have the coronary CT angio, which will also detect the gaps as in the coronary calcium score. Next slide, please. Then the risk category, like I said, use the American Diabetes Association to be able to establish it is a high risk, and if there is associated target of if it's low risk, that means diabetes with multiple risk factors like hypertension, dyslipidemia, and stroke. And if it's low risk, the age less than 35 years, type 1, 50 years or less than 50 will show a low risk. Next slide, please. And this also is the EASD and ESC classification to be able to establish which risk and when to start managing. Next slide. Now, to the practical cardiovascular assessment, I say some of these things have been used in research. So here you can do the clinical full history, we can do the diabetes symptoms, and we can assess features of heart failure and be able to input this when we examine patient group for signs of heart failure. Because there is also the angiotensin. Then the blood pressure. In this case, just like I said, they did not do an African or a Nigerian study, and it is said that they are yet to see a study that has validated all this in Nigeria. But in this meeting, I saw somebody comparing risk assessment, and it would be nice to see what they use and what will work for us. Blood pressure monitoring is very crucial for how many of our patients have this. So it is suggested they come regularly for blood pressure. ECG, we should be able to do that to detect arrhythmia, and it will also screen asymptomatic patients. Then you have the following laboratory tests that we have seen. The biomarkers are more frequently, but these are also things that we need to do. Then kidney function. It is said that where you cannot do everything, even a simple deep sleep from proteinuria may also be okay. Next slide. Then echo. Most centers have echo, and so can do that. Exercise strength testing will also guide us in then you have the advanced imaging as a. But the ankle breaker index, it's also another thing that we all commonly do, and this will also help in assessing cardiovascular risk. Next slide. So after assessing, we need to also monitor. So we should monitor them every 1 to 2 years, or if they have clinical, and then we consider to refer if they have progressive proteinuria or diabetic retinopathy and other risk factors, or heart failures or arrhythmias. And of course, as you know, in people who live with diabetes, it is not only the diabetologists that manage them, you have to have other people. So in summary, cardiovascular assessment in diabetes will involve a combination of the traditional, that's history, physical examination, ECG, lab tests, and imaging, and early and regular cardiovascular evaluation will help to reduce these symptoms. And management also include controlling blood glucose, blood pressure, lipids, and lifestyle modification. Next slide. So this is another table that just helps us on how we can assess from history, physical examination, laboratory tests. We use the risk calculators, knowing that some of them also have some limitation in that the population that they use did not include blacks from Africa. Of course, the managing plan will include lifestyle, drugs, and monitoring. Next slide, please. So in conclusion, cardiovascular disease remains the leading cause of morbidity and mortality in diabetes. In fact, I had a teacher who told me that diabetes is a cardiovascular disease and not an endocrine disease like we say. So effective assessment requires a comprehensive approach in which we use the traditional risk factors, we use diabetes-specific factors, and evidence of a target organ. And of course, the tools that we use include risk scores, biomarkers, and imaging. So a systemic and proactive assessment enables a timely intervention, individualize the treatment, and ultimately reduces the burden of cardiovascular disease in this high-risk population. So in diabetes, any cardiovascular assessment is not simple. It is life-saving. Thank you.
To present hyperthyroidism. We have 15 minutes and 10 minutes of
Good afternoon, everybody. Good afternoon, Chair, and everybody else. You're all very special and well done. So, in a few minutes, we'll be talking about hypothyroidism in children and adolescents. Okay, my name remains Akela, and this is where I work. So, when we talk about hypothyroidism in children, what exactly are we saying? So, it's a condition in which the thyroid gland produces excess thyroid hormones. And these hormones are largely triiodopamine and thyroxine, which we usually refer to as T3 and T4. And what do they do? The effects of the excess that it leads to increase metabolic activity in body tissues. So often we hear of hypothyroidism and thyrotoxicosis, and many times these names are used interchangeably. But the truth is that there's a subtle difference. For hypothyroidism, it comes from excessive circulating thyroid from the thyroid gland. In thyrotoxicosis, the source does not have to be the thyroid gland, so it could include exogenous sources of thyroid hormones. Hyperthyroidism is less common in children and adolescents than it is in adults, but it has significant impact on growth, on development, and psychosocial impact. While we do say that Graves' disease is the most common cause of hyperthyroidism in children, and has a genetic predisposition, paradoxically, it is rare because the incidence is 1 in 5,000. This is a slide, I hope you can see this one. It's a slide I like to share with my students, and we play the game and say, okay, so what's the likely diagnosis? And they give reasons. So the first picture was when the child or adolescent first came in, and with the treatment, it was looking like a different person. Don't you think so? Don't you think so? Yeah. Thank you. Next slide. So what are the causes of thyroid? Graves' disease remains the most common. Many reports leave it as 95%, some say 90 to 95%. You can see that all the other causes, they only share the remaining 5%. So when we talk about hyperthyroidism in children, most often we are referring to Graves' disease. There are other causes, and these other causes are highlighted in this slide. Okay. So I need to just say that there's some associated conditions with hyperthyroidism. Graves' disease may coexist with other autoimmune conditions like diabetes, type 1, celiac disease, vitiligo, amongst others. And that is because we know that when there is an autoimmune condition, that person that has an autoimmune condition is susceptible to having other autoimmune conditions. And children living with type 1 diabetes have a somewhat increased incidence of hyperthyroidism. At our center, we have recorded a case of a Graves' disease in an adolescent, and 3 years later, she developed type 1 diabetes. So, as I speak, we're managing her for both Graves' disease and type 1 diabetes, which also, since then has left us with a high index of suspicion to watch out for the children, because when we have one autoimmune condition, we develop others. Then, to also know that children that have Down syndrome and Turner's have an increased risk for developing hyperthyroidism. So ideally, we should screen them for thyroid disorders, including Graves' disease, periodically. Sorry, the slide appears small, but I just wanted to say that when we talk about hyperthyroidism, there could be many reasons for it. The most common, as we have inferred before now, is autoimmune. That's the most common. And there are other things. Inflammatory or destructive causes, iatrogenic exogenous causes, pituitary related, and rare causes like neonatal racism, which is another rare disorder, but we have also reported 1 incident of neonatal racism from our center. Next. Alright, so this is giving a brief of the pathogenesis with some notes of the mechanisms. So again, Graves' disease is autoimmune. The TSH receptor stimulating antibodies, they stimulate the receptors on the thyroid gland. What it causes is to cause the thyroid gland to produce more thyroid hormones. This is a bit different from what you have in hashimotosis, which in the preliminary phase may present actually with hyperthyroidism, and you are not quite sure whether you are dealing with Graves' disease or Hashimoto's. But in this instance, the thyroid hormones that are secreted, in the case of Hashimoto's, they're actually preformed antibodies. So they're not active. And so that means that the effects will be just for a short while. And afterwards, this patient with Hashimoto's will have a chronic hypothyroidism. So these are other causes. Exogenous, whether it's from too much prescribed thyroxine hormones, or maybe the person, an adult usually, on purpose takes excessive thyroid hormones. We don't get a lot of this in children, and then very rarely it will also be pituitary adenoma. So the clinical manifestations affect all systems, which is why sometimes it takes a while for the diagnosis of Graves' disease to be made. In our center, we actually looked at the time it takes for them to come to the clinic and have a diagnosis. Now we have seen that it takes as short as 1 week, and sometimes as long as 6 months. And the reason is because of these varied manifestations. So sometimes, let me start with the general manifestation. So generally, there is weight loss, in spite of the fact that we have good appetite. So sometimes you can increase appetite, heat intolerance, sweating, irritability. The cardiovascular system have all of that. And let me just say that heart failure is something that we do get, but arrhythmias, which I'm aware, they can present in adults. It's not something we often see in children. Okay, I just wanted to emphasize a few of these clinical manifestations. That in studies in Africa, particularly in Nigeria and Senegal, we have highlighted that the commonest presentations that we see, they are the weight loss despite good appetite, the tachycardia, the exophthalmos, and the diffuse coat. So they present with other things, but these are the commonest that we have been able to present from Africa. Next slide, please. Okay, this is another slide that I like to share with students just to make them understand that hyperthyroidism affects all the systems, and you can see that even from the picture. I also like to emphasize that to be able to make a good working assessment from the beginning, it's important to examine very well. And what we examine in particular the thyroid gland after a general examination. So if there's a diffuse non-tender water, in addition to the history, then you are almost, certain that you're looking at the diagnosis is a Graves' disease. And if the patient comes with exophthalmos, it strengthens your diagnosis. So that by the time you are even calling for that, you are already anticipating that the labs are going to support your clinical diagnosis of Graves'. If there's a single node of it, it's certainly not Graves'. So we are thinking about things like toxic adenoma, and there's multiple nodular growth. If the thyroid gland is tender, then we are thinking of subacute or infectious causes. And the history is likely to present with things like upper respiratory tract infection. And the child may have had a sore, or may even have a sore throat. So in such a case, if you probe more and you investigate blood counts and all of that, you may not even need to do much. If it's a viral infection, you just need to see what you need. If it's a bacterial infection, then antibiotics are in order. So what I'm trying to say is that you treat based on whatever is possible, even though that I said largely is Graves' disease. Okay, so diagnosis. Generally, hyperthyroidism, the TSH, thyroid stimulating hormone, is suppressed, and the thyroid hormones are elevated. And in the case of Graves', the TSH receptor antibodies are positive. So when we see positive TSH receptor antibodies, we are really saying that this diagnosis is Graves' disease. For imaging, what do we expect to see if you do an ultrasound? It will show that there is diffuse enlargement of the thyroid gland. And in a few centers where we do active diagnosis done, it shows diffuse uptake in Graves'. But that is not a diagnosis that, even in advanced or well-developed places, they rush to do. Next slide. So the complications cut across systems. There may be thyrotoxic crises, growth disturbances. I'm sorry. Thank you. Okay. And cardiovascular complications, heart failure. We have also had patients present breast in heart failure. So you have to address that heart failure before you now settle down and treat the Graves'. Osteopenia, osteoporosis, because there's result bone absorption and a lot of calcium and suppressed parathyroid. Next slide. So what are the management rules? Achieve euthyroidism, and then prevent relapse, prevent complications, and if complications have occurred, we want to treat them, and then we generally want to support the child to grow optimally. Treatment for Graves' disease, first line, usually anti-thyroid drugs. So carbimazole or methimazole is usually used. Proper thyroid is avoided in children because of the risk of hepatotoxicity. When I say carbimazole is preferred, it depends on the region, depends on the number of things, availability, cost. But generally, Europe prefer carbimazole, while North America prefer methimazole. So if you have patients coming from North America, they will come to you with methimazole. But ultimately, whether it's abimazole or methimazole, the mode of action is the same. And methimazole is actually the input product because abimazole is a pre-thought type of methimazole. So duration, usually for 2 to 3 years. So we counsel at the beginning that this is not something you're going to treat patients with. We're going to be patient, and the eye signs, so they may be there, but they are usually the last to go. So let me just quickly talk about thyroid eye disease. We do see thyroid eye disease in children, but it's not as severe as what we encounter in adults, as you saw from the first slide. So what do? We also monitor thyroid function and blood counts because of the risk of agranulocytosis, which is like 3. Beta blockers may be instituted at the beginning for symptomatic relief of sympathomimetic activity, for example, palpitations, tremors, anxiety, and all of that, because it starts working immediately while you're waiting for the effects of the antithyroid drugs to kick in. So the definitive therapy is radioactive iodine ablation, which again is rarely considered in children because of the long-term risk of developing cancer, of fertility, risk to fertility, and all of that. Surgery, thyroidectomy is another definitive therapy that is considered, but this is usually after this person with Graves' disease has gone into remission, and it's usually considered if the goiter is large or the patient is not compliant to the antithyroid medication. But whichever one of the approach, the complication is that there's hypothyroidism. So this person will need to be on place a lifelong levothyroxine for replacement of the thyroid function. Of course, we offer supportive care, education, psychosocial support, monitor the growth, monitor pubertal development, and school performance. Because sometimes again, they come with poor school performance. You would expect that poor school performance is more in hypothyroidism, but you do get that in hyperthyroidism as well. Prognosis, many children require prolonged therapy or definitive treatment. Early recognition, as in many cases, is important, and long-term follow-up is essential, especially after surgery or radioactive therapy. Okay, so these are some of my references. And I thank you for your time.
Thank you very much. We have just enough time to take one or two questions that can be addressed to any of the presenters. Professor Ogo, Professor Ike, Akila. Do you have any? Anybody have any question? One question. Yes, Dr. Arusialat. Please go ahead.
How many can be the diagnosis of hyperthyroidism in pediatric age patients? Because some months back, there's a particular baby with Down syndrome who I work that was in Lagoon Hospital in Kenya, and we don't have an in-house pediatric endocrinologist. So I think the pediatrician referred the patient. So occasionally I see those patients and give them advice, and then still see the pediatric endocrinologist who come on visit. So in this particular case, I think we had a thyroid function test where the TSH was normal and the creatine form and A3 were elevated. So it was a patient had Down syndrome. So I think it's a risk factor for thyroid disease. So my decision I took was we should repeat the TFTs in 2 months. I don't know how soon are there any interference with the thyroid function at that age, and how soon can we make that diagnosis? Thank you.
Okay, thank you. Any other question? Okay. So, Yes, thank you very much. Brief. I think my question goes to Dr. It's more of an observation and your opinion. For the patients that you discussed, I can see that the highs is almost getting back to normal. Is it because it's that is of course in children? So that most times in adults, you actually find them having their normal size, the eyes, never getting back to normal. What's your experience with children? And then two, what's also your experience with the skin in hyperthyroidism with children? Thank you.
Thank you, Dr. Akiola. So, I have some I usually refer pregnancy patients to me, but I don't want to see. However, I've noticed that the biochemical parameter between adults and pregnancies, they differ. Because, yes, I have some example, TSH is normal, T4 is normal. I'm looking at it. I look for Dr. University to send patients to many people.
Thank you very much. Looks like Dr. Akiola has all the questions. Okay, so sorry before Dr. Akiola, I have more questions for each of you, so you can Professor, we discussed this cardiovascular assessment. Is there a way, or maybe at least, to aggregate this particular individuals so that I can say that this is 1, 2 is low, and then also does the is it also important thyroid function assessment? Most of the osteoporosis and the thyroid also. So for some Dr. is now.
I won't say I have to do justice to this. Okay, Professor Lincoln, I did a lot of work on osteoporosis and in hyperthyroidism. A lot of papers have come out on that. I want to thank this opportunity to thank Professor Lincoln. She knows she's a mother. She knows why I'm thanking her. I don't know if you can osteoporosis usually presents a cognition disease, but that's an irony. It's not. It's with us here. I did some work on hyperthyroidism, patients with hyperthyroidism. 45% of them has osteoporosis. Even within my control too, there's still some level we have also been because we are in this part of the world, the sun ray, because we have melanin in our skin, it's disturbed the absorption of indirect vitamins. So we have a lot of osteoporosis. So we shouldn't count this as a disease of the population. We have it with us here. And another thing is that we have a lot of criteria too. Maybe those going for their part 2. You can read about FRAX and a lot of criteria. Please read about it. And I think I will encourage our younger ones that we can go to do a lot of studies in bone, a lot of studies, although it's expensive, there's still, even if you don't have desert, there are also other means that you can design bone density. Thank you very much, Professor Olu, for that presentation. Okay.
Okay. I just wanted to ask Professor Loco, brilliant one, thank you, and every other presentation. As a person who says what he just discussed, I want to ask, regarding all our endocrinologists are gathered here, is there a way we can, we are talking of prevention and also management, is it possible why most of our doctors don't go ahead to just give you supplements? It's not always what they do, isn't it? My experience. Is it possible, because we are preventing based on what we just had now, I'm going to go shopping for my vitamin D and all this, but of course, with my doctor working with me, is it possible that it's part of what you did do when you are seeing a patient at that age? Is it possible it can be a practice? You're getting to, you are already approaching menopause. Is it possible you start taking vitamin D to prevent also? That's where we come in, layman. So is it possible as part of your practice in Nigeria? I thank you very much for your comments and your questions. And it shows me that you were an attentive audience and that you thought postmortem and you won. So congratulations. Okay. I'm sorry. Yes. Some people miss lunch. I'm sorry for you. Lunch will close at 4 o'clock. Sorry. You will have lunch immediately after this session. All right. So for the first question, how soon can we make a diagnosis of brain stress? I think that's what you were asking. All right. What I missed talking about was that most of the diagnosis of brain stress we make is in adolescents and in females, and that is in keeping with what literature reports globally. Having said that, I told you about neonatal Graves' disease, and so if we can have neonatal Graves' disease, it tells you that we can also have Graves' disease even in younger people. And indeed, we see Graves' disease in young children, not just the adolescents. In the particular case you shared, you have done well. Because if you're looking at a child that has Down syndrome, that child is susceptible to thyroid disorders generally. That child may have congenital hypothyroidism. So ideally, any child with Down syndrome should be screened, should have thyroid function tests, because you want to, the one we are really worried about is the congenital hypothyroidism, because there's a double morbidity. If you cannot help one so much, you can't help the other one, and prevent the child from having very severe consequences. So we're looking at congenital hypothyroidism, we're looking at Hashimoto's in this child, we're also looking at Graves'. So what helps? Because all of them, thyroid function will be deranged. For Hashimoto's, depending on when you identify it, can be on either side. For the others, to their on the extreme. So I would what you did, wait 4 weeks, repeat it, and ask them to do antibodies. Because the antibodies will help you to distinguish many cases, whether you are dealing with Hashimoto's or you're dealing with Graves'. So that's what I would approach. I hope that helps. Yes, I did mention that thyroid eye disease is less severe in children and adolescents. So I think that's what accounts for that picture. In my experience, when you see them, because I have a habit of once the patient walks into the clinic, I'm looking at the patient from head to toe, and I'm trying to play a game. What's the diagnosis here? Like it's depending on how the person presents. But usually, when you see somebody that looks like they have lost weight, and you see the gaze staring, and they tell me, what do you think it is? And usually we're right. We're looking at Graves' because it's the commonest cause of hyperthyroidism in children. So, but we realize that if they are compliant with their medication, if within a few months, you would really even know. Anybody, any onlooker will really know that that person has a thyroid disease because most things would have subsided. But even though we counsel and tell them that it may take 2 or 3 years, but many of them, you can see considerable improvements in a short time. But the skin changes. Now that you mentioned it, I noticed that many of them, not many, but if we're talking to look at skin changes, what they actually present with at some point or the other is atopic dermatitis. So I wasn't really thinking about it, but is there something to it? I don't know. So thank you for bringing that up. Maybe it's something that we should look at. But other than that, there's nothing else on their skin. Not even the vitiligo. I haven't seen a lot of that. I hope that answers your question. Okay, yes, the thyroid function test, even though we classify them generally as children, but it's also divided. For example, the values you are likely to get in a unit is different from what you get in an older child. They may not be so marked, but a little difference can make a large difference into how you approach it and what you do. So, yes, thyroid function test results are slightly different in adults than in children because we classify our children based on their age. We don't give them a one size fits all as the adults do. Okay, I think I've answered all the questions and I thank you again.
Thank you, sir, for the question. You asked if thyroid function test assessment is important in post-menopausal women. Yes, it is, because we know very well that the hyperthyroid state can be a known risk for osteoporosis for reasons that the turnover time is shortened for bone in the hyperthyroid state. There is an imbalance between osteoblastic and osteoclastic activity in favor of osteoclastosis in the setting of hyperthyroidism. So, I was in the earlier, I skipped some slides. You would have seen thyroid function test assessment. So, before you return the diagnosis of osteoporosis strictly due to menopause, we must exclude other common causes of osteoporosis, and thyroid hyperactivity is one of them. My very good friend Chima was asking if my lecture should stipulate the recommendation for prophylactic vitamin D in perimenopausal women or women approaching menopause. There are no guidelines that I know that recommend that in anticipation of osteoporosis as menopause is approaching, you should start taking vitamin D. And also note that excessive intake of vitamin D carries consequences because you can get hypercalcemia and all the troubles of hypercalcemia, renal stones, and so on and so forth. So the best approach to it will be early evaluation, and if there are no risks for both developing osteoporosis, those that are amenable to treatment, treat. Those that are not amenable to treatment, you begin to make modifications in lifestyle because there are lifestyle issues to treatment and see. But once it's established that this is osteoporosis, then you give definitive treatment. Thank you.
Thank you, Mr. Chairman, for the only question. I thought I wouldn't have a question. Okay. I think I'll just say the day we run our clinic, we have the nephrology clinic there. And so they'll say, we refer your patients and make sure that our patients don't have the diabetic kidney disease, and so we will start the treatment. But the cardiology unit is where we call phase 4. So you see, it is very hard. And the tendency is that people always think that maybe these patients don't have the cardiovascular disease. But recently you will see that they have. I remember as a resident where I was doing my dissertation, the prevalence of hypertension in type 2 DMA was about 45%. By the time I finished, about 2 of my residents later did something that they needed to also check. One of them wanted to do DM with no hypertension, and another one. So you see, he had to change it. So, but the prevalence of hypertension had gone from 65 to 75. So you see, hypertension is always there. And this is one of the risk factors. So the question is there any way we can aggregate this risk in individual patients? Because most of the guidelines did not take into cognizance the Africans, not even West African, not to talk of our own. And that is why I was saying that they all said that none of this have been validated. But out of all of them, they gave some advice. And it's the Q risk 3. So that means there was 1, 2, 3. That was the one that was closest. Because it included multiple ethnicities. So one did not actually say African blacks. So, but they were blacks. And you know, blacks here and blacks in America, you cannot say they are the same. So what's this thing we use that? Because in this case, for the ethnicity, we just put black. So the score may not be for a British black, a Asian, or whatever, but that is the one. And in assessing cardiovascular, we have to individualize each patient. And so the traditional risk factors that we use are still okay. Our history, examination. Right, it is said that if a DM patient is greater than 40 years, has hypertension, is obese, that you can just put the person at risk of having a cardiovascular disease. But is this risk mild, moderate, or severe? So we have to now input the diabetes specific risk, in which we are actually do too. At least we do HbA1c, though it's costly. In this patient, we can assess all the microvascular complications that they have. We do lipids, we do ECG, and echo. Then it's actually the biomarkers. How often do we do the biomarkers in this patient? So we don't wait till they have features of heart failure before we do this. We also use it as a baseline. A DM greater than 40 has hypertension, is obese. We'll screen them just like we screen for microvascular complication and individualize their treatment. Because it said it's not all of them that may require statin, but there are some that will require statin. Some people are okay, statin if they are hypertensive. Thank you.
I think I just appreciate all our speakers, and I've called them out on my one day of plan here. Talk about some of the system. The first is Dr. This in our position of the role as speaker at our 46 our general meeting outside. Also, on behalf of the President and members of the President of Nigeria, I'm happy to present you this plaque recognition as a global speaker at the 46th AGSM. Thank you. So, a round of applause for all our